Hello, everybody. So, I'm going to be giving you a lecture now on alterations in pediatric neurological conditions. As always, it's usually helpful to go over the learning objectives so that when you're studying, so that you understand the types of topics that you were intended to glean from this presentation. The neurological system in the pediatrics population, it's very much the same as adults, except for that the myelin sheath is less developed in pediatric patients and less organized. The infant brain develops rapidly until age 4, and that is why it is so important that we provide stimulation early in childhood to the child. They need visual, auditory, and tactile stimulation so that their brains grow and develop properly. Newborns have smooth brains. The a more mature brain has more wrinkles in it. And so that's one of the changes we're looking to see because as the child grows and develops more cognitively, you'll see more wrinkles in the brain, and that's equivalent to higher um, levels of cognitive development in pediatrics. The suture lines on babies, they tend to be open all the way up until age 12 is when they're completely closed. The center suture line you can't feel anymore after the baby's about a year old. It's most palpable when the baby's a newborn, and you'll feel that ridge down the center line. And that the purpose of that center line is really important because it helps the brain. As the brain's growing, it allows for the skull to expand as the brain grows. One of the other things that's important about that center suture line is that if the baby has intracranial pressure, in an adult, the skull doesn't stretch to accommodate that. So if there's intracranial pressure, the brain will herniate down the foramen magnum. But in infants and small children, if they start to have intracranial pressure, their skull will actually spread and accommodate. So that's actually protective in newborns if they have a little bit of intracranial pressure. And that's one of the reasons that we take, when we do assessments on newborns, we take the measurement of the cranial circumference. One reason is that when we take that circumference, we can tell that the brain is still growing, which is important. And we document that using a growth chart similar to the height and weight on the CDC growth chart. There's also a growth chart for cranial growth. But also, if the child has intracranial pressure, then if we take hourly or, every 4 hours, if we take measurements of the cranium, we can also tell how fast that cranial expansion is growing, and that's related to the amount of pressure they're receiving. The suture lines in the skull are not fully ossified until the child is 12, and that allows for the head to continue to grow, especially around the jawline. As you see, as more teeth come in, the jaw should get bigger, and all over the skull you can see that it expands, but they're no longer palpable. Myelinization continues to occur as the baby develops, and this is important because you'll notice in a newborn at first they don't realize they have hands. Then you'll notice a few months later they notice that they have hands, but they can't coordinate the movements that well. And then as the myelination continues to improve, you'll see that they'll not only know where their hands are in space through proprioception, but also they'll be able to pick things up and coordinate their movements. So that's all part of the growth and development of the newborn neurologically. I'm showing a picture right now of the structures in the brain, and you had this previously in your anatomy and physiology class. The things to remind yourself about this picture, first of all, remind yourself of what is the purpose of the ventricles in the brain? Remember that they're filled with fluid, and the cells that line that ventricle are actually goblet cells that produce the fluid in there. And that will become important in things like hydrocephalus, which we'll talk about later. Also, remind yourself of the blood vessels that go through the dura mater, from the brain through the dura mater to the skull. That'll become important if you have a head injury, because as the brain sloshes around in the cranium, those small blood vessels can shear off and create hemorrhaging. So those are the main things to notice here. And also, I want you to notice how if you had an infection in the spine, it's connected to the brain, because the dura mater is continuous throughout the brain and the spinal column. So if you have an infection in the spinal column, it will travel to the brain. And if you have an infection in the brain, it will travel to the spinal column, because it's all one place. I also want you to notice that there's um, all those little grooves in the brain, and those are places where infection can grow. And as it grows, it can become pussy and have you can have pus-filled pockets that actually destroy part of the brain. And that's something that we worry about a lot in kids that have meningitis, because everywhere where pus grows, you're losing brain tissue, and that's very serious. A lot of times it's permanent kind of damage. This picture shows the different suture lines I was telling you. So as you know, that you can palpate the center suture line down the center of the head when the baby's a newborn, and you probably palpate that up till the baby's about 2 months old. After that, there's still all these other suture lines that you can see that help the baby's head grow, but you don't feel them, and most of them start to close at different rates. But like I said, the parent won't notice it, and you won't notice it unless something goes wrong with the brain development, and then we'll notice it. So in the first week when we did front loading class, we talked about the Glasgow Coma Scale and how it doesn't really apply to pediatrics, because infants and newborns, they can't follow verbal commands and whatnot. So just to remind yourself that there's a separate GCS scale for infants and newborns. The level of consciousness is different, as we've talked about, because you can't be oriented to person, place, and time. If you're a baby, you don't know who the president is and all that. Also remind yourself of the cranial nerves. There's 12 of them that you had to memorize in A&P. I don't test on them, but you need to remind yourself of them. Also, remember to thoroughly palpate the skull every time you're doing an assessment, especially the fontanelles on newborns. Don't just assume that they're normal. So if the fontanelle is depressed and sunken, you know that the baby has dehydration. If it's bulging, it doesn't mean that they're overhydrated necessarily. It means that they have increased intracranial pressure. And so that is something that you want to notice right away, because that can lead to brain herniation. Brain herniation is permanent. There's no coming back from it. There's no cure for that. It's permanent damage. So you need to recognize that that's something that needs to be intervened on immediately. Pupils are very important. So when you shine your light into the baby's eyes, you need to have, equal and round reaction. You don't want to ever say that newborns can accommodate, because they can't. But once they're like 2 years old and they can follow simple commands, they can accommodate. Also, if the parent doesn't like you shining a light in the baby's eyes, you can always use the blinds, close the blinds in the room, or shut the light off, and then turn them on again, and you'll see that contraction. Also know that if there's intracranial pressure, there's this thing, you'll see changes in the heart rate, the respiration, and the blood pressure, but these are late signs of intracranial pressure, later signs. And this is called the Cushing triad. We'll talk more about that in a little bit. You'll also see bradycardia and irregular respirations as the pressure gets worse. Also, we'll talk about posturing and movements and how that's associated with alterations in neurological status. And then the most important thing that we look at that's related to meningitis, if the child can't put their chin to their chest or turn their head left to right, if that causes pain at all, that is called nuchal rigidity, and that is bad. That needs to be reported. It's associated with meningitis. I don't test on this particular image, but you should look at it just to be reminded of which cranial nerves are associated with which movements in the face and the neck and the shoulders. It's very helpful for you to keep reminding yourself of these cranial nerves. One particular pet peeve that I have is when I go in the hospital and I read nursing charts, and I notice that even experienced nurses sometimes make a mistake between how you refer to a patient that has decreased level of consciousness. So lethargy is defined as excessive slumber, sleepiness, changes in speech pattern, movement. The child is very sleepy, they fall asleep easily, but also they awake pretty easily. If you talk to them, if you stimulate them, they wake right up and then they go back to sleep again. That's called lethargy. And I like to say that this is how you might be if you had a couple beers after school. You go home and you feel lethargic, then you go to sleep. So it's not very serious. It's usually, we're saying that it's a little bit more than normal, like if you had no alcohol, right? So for kids, this would just be a little bit more than normal to call it lethargy. They fall asleep more than they should. Obtunded is a word that you use. It's imprecise because it's subjective. So when I say somebody's obtunded, and it might not mean the same thing it means to somebody else if they say obtunded. So the best way to think about obtunded is it's somewhere between lethargy and stuporous. Stuporous is when the patient has a deep sleep and they're mostly unresponsive unless there's painful stimulus that's vigorous. So think about doing a sternal rub or digging your fingernails into the child's fingers or doing something painful to them. They wake up momentarily, scream, and then they immediately go back to sleep. That is stuporous. So obtunded is somewhere in between the two. So be careful, because the reason I would say this is because if you say a patient's obtunded and they were just really tired because we kept them up all night, that tells the doctor or whoever else is reading it that there was something neurologically wrong with them that was more serious than if they were just lethargic. So be careful with the words that you choose. I would say obtunded is how you would feel maybe after 3 shots as opposed to 3 beers. And I would say stuporous is how you might feel after 5 to 6 shots. And that depends on each person. I don't know, but that's going by me, probably. Coma is when the person's unconscious completely and cannot be aroused even with painful stimulus. So, altered states of consciousness indicate neurological dysfunction. And this is why I was saying that I'm kind of picky about saying someone's obtunded when they're not. Because what you're saying is they have a neurological dysfunction. So, you want to assess their alertness, their cognitive power, their Glasgow Coma Scale, and you want to note any changes in time. So, that means you need a baseline, and that means you need to reassess it every hour, especially if they're a neurological patient. You should do a reassessment of their neurological state every hour. And also note if they're delirious. I've seen that also used interchangeably with the term stuporous. So delirium sort of indicates a patient is um, making wild kind of statements that indicate that they are not aware of reality. So a delirious patient might talk about their pet that has been dead for a while or something like that. So try to make sure that you have a sense of what these different words mean. Intracranial pressure is something that can rapidly progress to permanent brain damage. So, at first, when you have intracranial pressure, we don't worry about there being permanent brain damage immediately, but there's a small window of time where we can intervene and save the brain. So, early signs, it's really critical that you notice early signs. And like I said, with babies, if they're nonverbal, they can't tell you what's wrong. So, you have to be really in tune with the neurological signs. So, early signs of intracranial pressure are a headache. And the baby doesn't say, I have a headache, but they cry. If they're old enough to speak, though, they'll say that their head hurts. They'll have visual disturbances, so they might say, like, I see stars or flecks or something like that, or they might be dizzy or say everything's blurry. They'll have nausea and vomiting, but it's especially notable if it's early morning because if you think about it, most of the time when you get nauseous and vomity, it's later in the day. Their pupils will be unequal and slow in their constriction, and infants will have an increase in their head circumference and bulging fontanelles. Those are early signs. Late signs. This means that we really don't have that much time to act before there's brain damage. So there's a significant change in their level of consciousness. They have an increased systolic blood pressure. They have bradycardia, irregular respirations, and fixed and dilated pupils. Fixed and dilated pupils are very late. This slide I've just included to give you more visual signs. And you should remember when you're testing on this that if you don't notice the words early or late, you could get the whole question wrong. So when you're taking the test, I want you to pay extra special attention to if I ask for early versus late signs. When someone talks about fixed and dilated pupils, they they are it's often a Hollywood type setting that you think about. So a lot of times we don't know what that means. A lot of times you hear the word that someone's pupils are blown. And what does that actually mean? So a pinpoint pupil is this one that you see on the bottom left in the C line, and that is like a pinpoint pupil. It might be so small you can't even see the pupil. The one on the right here at the bottom, that is closer to a blown pupil, and sometimes it's so big you can't even see any of the iris around it. That's what they mean. And when they say that it's fixed, that means that it doesn't change at all when you shine a light in there. This slide is showing posturing. So, when children or adults are having severe neurological changes, first you'll see this decorticate posturing, and then it'll move to decerebrate. And this is generally in patients that have a very high Glasgow coma score. So, between the two of them, decorticate should come first. And the way that I remember the difference between the two of these, the hands in the first one, decorticate, the hands are facing to the core. When you have the decerebrate, the hands are facing away from the cerebellum. So that's why it's called decerebrate. And another way I remember which one's worse is I remember that the second one looks like an angel. That's what I was taught in nursing school, that it looks like an angel and they're going to heaven. So things that cause altered level of consciousness in children, one of the most common causes is meningitis. So we'll get into this more, but there's three different causes of meningitis. You have bacterial, viral, and fungal, and we'll talk about that. But most of the children that are admitted for this We don't know for sure that they have meningitis, but we proceed as though that they do until we can prove that they don't with labs. Then the next second most common cause is trauma. And by trauma, I mean shaken baby syndrome. It could be a bicycle accident. It could be a car accident, something like that. Hypoxia, it could be that they had sudden infant death syndrome. They could have had cord compression. They could have had a near drowning incident. So anything that causes hypoxia. The next most common one is poisoning, and it could be anything. Think carbon monoxide might be a typical one that causes hypoxia related to the excessive carbon monoxide. Then seizures is high on our list of causes. So when a patient is seizing, a lot of times they lose their airway, and that causes hypoxia. We also have for causes alcohol and substance abuse, which depress the respiratory drive, and that causes hypoxia. Then we also want to think about diabetic ketoacidosis and other potential metabolic disturbances. We want to think about electrolyte and acid base balance. And then brain tumors, space occupying lesions can also cause altered level of consciousness in children. And then less common, but it's still there, is stroke and congenital structural defects. So now we're going to focus in on seizure disorders. So there's different types of seizures. Most of them are caused by GABA imbalances. GABA is a neurotransmitter that's responsible for transmitting signals across the brain, and sometimes you can have an imbalance in that hormone or that neurotransmitter that causes the cells in the neurosystem to be more hyperexcitable. The more excitable that neuron is, the more it's like an electrical imbalance that causes it to overfire, and that the overfiring is what we call a seizure. Seizures can also be caused by structural problems, trauma, tumors, and electrolyte imbalances that affect the firing of that neuron. Then seizures can be classified as partial or generalized, or focal, and that has to do with how much of the body or how much of the brain is affected by the seizure. One of the important jobs of the nurse is to record the time, and that's fairly high priority, because you need to know exactly when that seizure began, because a seizure that lasts more than 30 minutes is potentially life-threatening. And if a patient has two seizures back to back with less than a 5-minute break, that counts as one seizure. So you want to record every time that a seizure starts and when does it stop. You also want to know if anything triggers it. Some people are triggered by flashing lights or sounds, or it could be a smell. They also come with auras. So did they see flashing lights, or did they smell something when the seizure was about to start? Um, Young children have seizures that are associated with fevers, and that generally happens, it's called a febrile seizure. That generally happens with temperatures that are over 102 Fahrenheit. That doesn't mean every child that's over 102 Fahrenheit is going to seize. Most kids, if they're going to seize, it happens at 104 degrees Fahrenheit plus. But 102 is when we start to worry and try to get it down. Generally, when kids have febrile seizures, it doesn't mean they're going to have a febrile disorder. They may never have another seizure again. However, they are at higher risk for having epilepsy after that. Generally, they don't have these seizures again unless the seizure lasted more than 15 minutes. If the seizure lasted more than 15 minutes, these are the ones that we worry the most that are going to have some long-lasting seizure disorder from it. And that's because every seizure causes a little bit of brain damage, and that makes them more at risk for having more seizures. The seizure can be classified as simple or complex, and that has to do with how much of the body is involved again. And then the stages of the seizure, they are tonic, which means they're stiff, and then they go to atonic, which is floppy, and then they go back and forth, and so that causes the jerking motion. So that's called a tonic-clonic seizure. Um, Clonic seizures are often violent, um, and I have included a video here for you to review. I want you to stop the video and come back to this after you've watched it. I'm going to assume now um, that you've watched it. So I'm giving you a minute to do that. In the video, you'll notice that there's a patient that's having a seizure and there's two nurses at the bedside. I want you to notice what you've read in the book about what the nurses are supposed to do in what order, and notice if the nurses are doing it that way. What you're going to see is that most students, and the book probably says that you never suction until the seizure's over. You always put the bed flat. You always roll the patient in the sideline position, and you don't see that happening in this video. So why is that? So first, why is the head of the bed still up? The reason is because the nurses are both standing by and they have suction and oxygen available, and all of that they can do best while the patient's sitting up. If the patient was not, if they didn't have any of that, they would put the bed flat and they would roll the patient on the side. If the patient had a seizure and they weren't in bed, they would put the patient flat and roll them on the side into rescue position. So the only reason they're not doing that in this scene is because the patient's in the bed and they have everything they need right there. The next thing I want you to notice about this is at what point do they put oxygen on the patient? So they put on a nasal cannula on the patient, and they do it, if you look really close at the video, they do it when the patient's turning gray. The patient, there's generally an intermediate before the patient turns blue. And so if you look real close, you'll see that their mouth is a little bit bluish. So they put the nasal cannula on. Your job as the nurse now is to notice if the patient needs an oral airway. So you have to have an oral airway at the bedside, always as part of your seizure precautions, and you need to have a nasal trumpet because then you can decide which one you'd rather use. Both of those are effective if the patient's tongue goes in the back of their mouth. Also, at this moment, the nurse needs to consider giving Ativan or some other benzodiazepine that's available. So part of seizure precautions is you have to have a benzodiazepine available in the MAR so that you don't have to go get it. Another thing is while a patient's seizing, you can't leave the bedside. So if you're in the room alone, you need to call help to the room. So somebody can bring you that Ativan if needed, but you don't leave the room to go get it. Another thing I wanted you to notice is that the other nurse starts suctioning, and you might have read in the book that you don't suction during a seizure, so why is she putting the suction in the patient's mouth? What I want to say about that is the patient has stopped the tonic-clonic portion of their seizure, and she doesn't start suctioning until the patient's relaxed. So the reason we don't suction during the seizure is the patient might break their teeth. So that is why she waits until the seizure's essentially over to start suctioning. So what she's doing is right. Also try to note the time that you think the patient goes from being in a tonic-clonic seizure to an ictal phase. A post-ictal phase is important because the patient's no longer technically seizing, but they're not fully conscious either. And that phase can last to up to 30 minutes. And often the patient will have complete amnesia of anything that you do or say at that point. So you wouldn't want to try to talk to them or engage them. Their brain has exhausted all the glucose in their brain, and they really, they'll often drool, they'll be flaccid, and they won't be able to remember much of anything. There's another type of seizure I want to point out in the next video. It's called an absence seizure, and I've actually included 3 videos here for you to look at. So I'm going to wait for a second while you watch them. 3, 2, 1, and I'm going to assume you're coming back now. So one of the videos You had a baby named Brooklyn, and Brooklyn looks like she's fine. She doesn't look like she's jerking. She's having an absence seizure. And what that looks like in babies is they start to have rhythmic sucking in their mouth. In some cases, they'll look like they're swimming with their hands, or they'll have some sort of movement with their eyes where they look up into the right or the left corner, and they just have this moment where you can look and know that they're not there. They're not responsive. They don't respond. And then the next minute they're back. And that's important to teach the parents how to recognize that because, again, if this goes on for more than 30 minutes, it could be a medical emergency and they need to call an ambulance. So they need to recognize it first, but then the parent also needs to be taught how to time it and when to call for help. The other two videos, you'll see the child that has the absence seizure is older. And if you were an outside observer watching this child, they continue walking in circles. They just keep doing the last thing they were doing. And when the seizure stops, they stop doing that repetitive motion that they were doing. So an absence seizure often involves them doing a repetitive motion, and they won't have any memory of doing that repetitive motion. So this is something that teachers also have to be aware of because it can be interpreted as though the child's daydreaming, and I want you to remember the words daydreaming. Another phrase that's used about kids that have absence seizures is that it seems like they're off in their own little world. And they get misdiagnosed as having ADD or something when they're actually having seizures. So in infant seizures, you want to look for subtle eye movements, especially to the upper left or the upper right, rhythmic sucking when there's nothing in their mouth, like they're not on the breast or a pacifier, and then swimming type motions with their hands. Also in all kids, and this goes for adults too, the post-ictal phase can last for 30 minutes to 2 hours. They're confused, they're lethargic, and they have paralysis. So you shouldn't try to walk them during this time or do anything strenuous. It's also a good idea to get a blood sugar during this time. Treatment, our first line treatment, and you should remember this for tests. What is the nurse's priority? So, what should the nurse's priority of care? Is if it was between timing the seizure and giving a benzodiazepine, which would you think is the nurse's highest priority? And I'll wait a second for you to answer. The answer is the nurse's highest priority is the benzodiazepine because that will actually stop the seizure. Well, if I asked you what should the nurse do first, the thing the nurse should do first is note the time of the seizure. So those are two different questions, and I don't want you to get confused on the test. The priority is to stop the seizure, and the benzodiazepine is most likely to do that. The next highest priority, and you probably already know this, is the ABCs. So it's going to be applying oxygen and protecting the airway. Treatments are, you have to get an MRI and a CT exam to see if there's any structural cause for the seizures. And oftentimes, patients, kids and adults, they have seizures at home. The person that witnessed it, they don't know. They're not medical people if it was a real seizure. A lot of times, if you pass out because you're dehydrated, when you wake up, it can look like a seizure. So patients like this will get admitted and they'll have 24 hours of observation with an EEG cap on their head and a camera, and they'll be watched. And what the doctors want to see is if they have a seizure, if they can get it on camera at the same time that they can get a picture of the brain waves at the time of the seizure. This will confirm that it really was a seizure and not just that they passed out. That's important because they want to know what parts of the brain are involved in the seizure, and that tells you a lot about whether the seizure is treatable and how severe it is. Surgical interventions that they can do, they can scrape the brain with cautery. They can ablate, do electroablation of the part of the brain that's seizing. They can treat with medications, but intractable seizures are seizures that continue even if you add on 2 or more medications. They also have this device called a vagus nerve stimulator, and it's like an AI device. It basically goes in your brain and it learns the brain waves that you have right before you have a seizure, and it gives you a shock to your vagus nerve to shock you out of having the seizure before it occurs. And this is not everybody's a candidate for this, and it takes a little while for the device to learn your particular brain waves. Another thing they can do is, well, a lot of parents do the ketogenic diet because it's believed that the excessive glucose in the brain causes seizures, and a lot of parents swear by that. I don't know that there's full scientific evidence, but we never stop parents from having their kids on a ketogenic diet if they think that works because it's not going to harm them. And then finally, in extreme cases with really intractable seizures, they can actually cut the corpus callosum so that the right and the left brain can't communicate if that's the source of the seizure. And on younger kids, there's been cases of them removing the one entire hemisphere of the brain because sometimes the seizure is entirely focused in one hemisphere, and removing that hemisphere, um, the patient's obviously going to have some deficits, but in smaller kids, they have neuroplasticity, and the brain's actually able to rewire itself to get by without a section of the brain. And some of those patients, there's been cases where those kids have gone on to college. If you have an adult have that happen, they don't have the same neuroplasticity and they'd be less successful for that. So really that treatment works in younger kids or not at all, probably. Status epilepticus is a medical emergency, and this is what we call it when the seizure lasts more than 30 minutes. Patients are more likely to die when the seizure's gone on this long, and this could be 2 or 3 or 4 seizures even that are back to back without a recovery phase. So this is why it's so important that you record when you think a seizure stops and when it starts again. You want to give the prescribed medications slowly. So a common drug order will be to give Ativan every 5 minutes until the seizure stops. And then it'll sometimes have a maximum dosage that you can't go over. So it might say um, Ativan, whatever milligrams, times 3 until seizure stops, or maximum 3 doses. That would be something typical because there's only so much Ativan you can give before it harms the patient. So, and that's why you would want to give that slowly to not have it cause an overlapping problem with the patient. The other thing you want to be aware of is what are seizure precautions. So let's talk about that real quick. So what you're supposed to do, and like I said, they didn't do it in the video, so this is nursing judgment, but what you're supposed to do, especially if you don't have an equipment handy, is to lower the head of the bed and roll the patient on their side into rescue position. If you have all the equipment necessary, you might skip that. Another critical parts of seizure precautions are you have to have all 4 bed rails up, and that is not considered a restraint. When patients have seizure disorders, you don't have to mark that up as a restraint. They also need padding on the bed rails, and if you don't have hospital approved padding, you can always use pillows and tape them to the bed rails with silk tape. They also have padding in some hospitals where you can put it on the floor, and it looks like yoga mats but thicker, more like gymnastic mats. If the patient is walking or ambulating when the seizure occurs, you would want to ease them to the ground without letting them hit their head, if possible. Other seizure precautions, you're supposed to have an oral airway at the bedside at all times and a nasal trumpet. You're supposed to have an ambu bag or a self-inflating um, uh, positive pressure ventilation system. You have to have oxygen and oxygen tubing. you have to have an IV established already, because if they don't have an IV and you want to give a benzodiazepine IV, you can't start an IV while someone's seizing. So it's critical that they have the IV before they seize. You also need to document while the seizure's occurring everything that's done. And then for your teaching, you need to teach the patients about all their meds. For example, in teenage girls, some anti-epileptic medicine can cause birth defects if they become pregnant. So they need to know that. Other things that are really important to teach patients with anti-epileptic drugs, they're never supposed to stop them abruptly. So they can't miss doses or skip doses or take themselves off a dose medication. But also, teenagers, this sometimes is a problem. They're never supposed to drink alcohol when they're on an epileptic medication. You also have to teach the family and the child what they're not allowed to do. So, activity restrictions are going to include things like think about what you couldn't do if you could possibly seize or and have a problem. So, for example, skiing, probably not a good idea. Horseback riding, not a good idea. Hiking in the forest, that's fine if you have a friend, but you would need to plan for what would happen if they seized out in the middle of nowhere and you didn't have help. So it's probably not a great idea even with a friend. Kids that have seizures cannot even shower alone because you can drown in 1 inch of water. They're never supposed to be in the bathtub alone, and if they go swimming, they can only swim with help. So you want to teach the family all the things they're not allowed to do. Some kids seize 150 to 200 times a day. When their seizures are that bad, they need helmets in case they get hurt because they're going to fall. We also want to teach them about avoiding triggers and about checking glucose level after a seizure. One of the things you want to monitor your epileptic patients for is depression and suicidal thinking. It's hard to tell if it's the brain damage from the epilepsy that causes the depression or suicidal thinking, or if it's the fact that it's just depressing to think about living your life with all these problems. But epilepsy and seizure disorders go hand in hand with depression and suicide. Also, there's a can be a significant effect on the child's learning ability. If you seize once a week or less, it's probably not too bad. But if you have a child that seizes 20 times a day, 50 times a day, think about also the post-ictal phase and how that can last for 30 minutes after the seizure to 4 hours. There's not a lot of learning that's going to occur, and those child are going to have significant developmental delays. Um, Also, you want to think about what it means to an adolescent if they're not going to be able to drive. In most states, people with epilepsy are not allowed to get driver's licenses. And if you're a teenager looking at a life where you're never going to be able to take a bath or swim alone, it can be very depressing. Some kids, they have a real significant problem with this idea that alcohol is contraindicated. They also need to consider med alert bracelets in case anyone finds them down. Um, Remind your teenage girls that their medications could be tetragenic. And sometimes that's important because let's say you have a teenager, let's say they're 18 and they get married and they want to have a baby. That's fine, but they need to talk it over with their doctor on how they're going to handle that. Like if they're going to go off the medication or if they're going to take the risk and have the baby while they still take their medication. And then, of course, you wouldn't want accidental pregnancies while they're doing that. And then sports, teach them what sports they can do. Some kids have seizures that are so extreme that they're no longer able to get out of bed or live independently anymore. These kind of children are usually in a neuro restorative unit, although they could still be on home care. But the considerations for a child in that case would be nutrients, so they're going to need NG tube feedings, sensory stimulation. So even though a child might have profound deficiencies, they still need to be stimulated. So even if a child's nonverbal, um, you would read to them, you would play music. Um, Kids that have neurological problems, and this goes for adults too, they often can't close their eyes. And even a patient that's having a prolonged seizure, they won't blink as often as they should. So, one of the interventions you can do is tape their eyes shut during the seizure, or give artificial tears while they're having an issue. Kids that are on long-term disability and being bedbound, they need to be turned every 2 hours, and you want to watch for those pressure points where they can have uh, pressure ulcers. Provide passive range of motion. Make sure that they also always have SCDs on. Make sure that they have a boot to prevent foot drop, and provide family support. This is some important questions to ask the family. You want to know what happens just before the seizure, during the seizure, and after the seizure. And this is why the interview is really, really important when you have a patient being admitted for new seizures. I'm going to shift gears now and talk about bacterial meningitis and viral meningitis and fungal meningitis. So, when a child presents that has nuchal rigidity, fever, lethargy, vomiting, and headaches, those are key signs that they might have meningitis. At that moment, we don't know if it's bacterial, viral, or fungal, or even it could be something completely different, and maybe it's not meningitis at all. So we'll often admit them, and we'll do a workup as though we'll assume they have meningitis until we're proven wrong. So what we're going to have to do then, that means we're going to have to get a lumbar puncture. And then the lumbar puncture, we're going to have to send that off to the lab to test for bacteria. And even if there's no bacteria in it, it could be viral meningitis. So so we'll talk about that more in a minute. But other things that go along with bacterial meningitis, it can be caused by a head trauma. And that's because during the head trauma, you can have a broken blood-brain barrier. Think of a basal skull fracture or a penetrating head injury, where you could get bacteria across the blood-brain barrier by that route. Also, patients that have nasopharyngitis or otitis media or dental procedures, um, technically those shouldn't cross the blood-brain barrier, but occasionally when people have infections that they've let go way too long, you can get an abscess, for example, let's say in your upper dental area. If that abscess goes deep enough, it can actually cross the blood-brain barrier and cause meningitis. And then also, anytime you have a neurosurgery or a spinal surgery, that could puncture the blood-brain barrier and introduce potential bacteria. Other risks that are associated with this are neurosuppression, having a shunt, having cochlear implants, or skull fractures, and then complications that are associated with bacterial meningitis. You can have permanent disability, you can have SIADH, DIC, you could have hearing loss, and you can have permanent seizures associated and death. Viral meningitis, you have less severe symptoms. So with bacterial, you would have a high fever. In viral, you would have a low grade fever. So you would still have a fever, but instead of being in the hundreds, it would be in the low hundreds to 90s, right? Like 99.89, something like that. You would also have lethargy and irritability, malaise, and a maculopapular rash. There's been immunizations for viral meningitis for some time, and the main vector for acquiring this virus has traditionally been something that we associated with sports, sporting equipment, locker rooms, and that's why kids would traditionally get the viral meningitis immunization around middle school when they start to join those kind of sports. Nowadays, they're doing it younger because viral meningitis can hit younger than that. And also, it's newer information that they have developed bacterial meningitis vaccinations, although I don't know how many people actually get that kind of vaccination. I don't know how popular it is, but the viral one is on the schedule, whether they like it or not, they have to get that one. And then I don't talk about it much, but you should know that any there could also be fungal meningitis, and that's also caused by puncture injuries and surgeries. If you have to break the blood-brain barrier and get it from surgical instruments or something of that nature. So nuchal rigidity, there's a test to do that. It's called the Kernig and Brzezinski sign, and we went over it at the beginning of the class. There's another picture of it in this slideshow, so if you don't remember it, hold on tight because you'll see a picture of it again. Also, photophobia, crossed eyes, pain, especially with moving or changing positions, projectile vomiting, early morning vomiting, hyperflexion of the neck at rest, a high pitched cry, and I mean a really loud, terrifying cry, hyperthermia or hypothermia in infants, and possibly brain abscesses. You might see those on MRI or CT. So, the nurse's job, one of your first priorities when you have a patient that is suspected of having meningitis, remember I said they're admitted usually, and we're going to treat them as though they have it. So, first, what you're going to have to do is arrange for a lumbar puncture. The doctor has to do this, but the nurse usually has to assist. So, the question is going to be, should they be on their side or should they be sitting upright? A small baby, you can control the baby and the baby can't move, so upright is safe. If you have, say, a 2 or a 3-year-old, they can move and they're stronger than you think. And so a lot of times we'll prefer to have them side lying because the nurse can control the child from moving. Remember, you have a large needle in the child's back, and this is true for adults too. You have a large needle in their back. You don't want them to move and damage any of those descending nerve endings in the spinal cord. They need to be held still. Part of your job is to hold them in this C position, and you can see that really well with this baby. This is often a very painful position if you have meningitis, because remember I said that they suffer the most pain when they're chin to chest, and that's exactly the position you put them in for this. So this is going to be horrifically painful for the child if they actually do have meningitis. It's going to be difficult. While the lumbar puncture is in place, there, if you can see in this picture on the far left, there's a tube that comes out. That tube is meant to measure the pressure in the spinal column, and the higher the fluid goes, it's measured in millimeters of mercury. The higher it goes, the more pressure there is. Once they know that, that's important because the pressure is related to intracranial pressure. So we want to know that. The next thing you want to do is look at the fluid. Normal fluid is clear or it might be slightly yellowish. If they have a bacterial infection, it'll be cloudy. Sometimes the bacteria is microscopic and it hasn't advanced enough for you to actually see the cloudiness yet. But if you saw cloudy fluid, you could assume that it's either bacteria or fungal. If it's viral, if it's clear, it doesn't mean that they don't have meningitis. It just means that it's not bacterial or fungal. It could be viral still. So the next thing they'll do is they'll take this sample and they'll send it to the lab. And this is important because it's going to take 8 hours for them to grow the bacteria and know what the organism is. They'll know if it's gram-positive rods or cocci or gram-negative. And then it's going to take 3 days for them to know which antibiotic it's most susceptible to. So in the meantime, we can't wait for that because the patient will be dead if we waited for that. So they're going to start broad spectrum antibiotics immediately after this, and then just continue that until they know whether the child actually has meningitis or not. If the bacteria or if it comes back negative for bacteria or fungus, they will stop the antibiotics completely because even if it's viral, you don't fix that with antibiotics, and they would just do supportive care. If it came back and it was showing that they need a different antibiotic, they would switch the antibiotic at that time. And that's important to know because broad spectrum antibiotics destroy all the normal flora in the body. So the quicker we can get them off that, the better. So we definitely want to know that. One of the biggest mistakes new nurses make is that they start the antibiotics accidentally, not thinking before the lumbar puncture. That's one of the biggest rookie maneuvers a nurse can make because it'll make the doctor really upset. And the reason is because we're not going to be able to ever tell if they really had meningitis or not, probably from that. And we won't be able to change them to a more narrow spectrum antibiotic since we won't be able to know. So that's important to always remember. If I was to ask you, now here's another question. If I was to say what's the nurse's highest priority for this patient, it's to get the antibiotics because that's going to save their life. If I was to ask you on a test question, what's the nurse's first action? It's to get the lumbar puncture. So remember, those are two separate questions with two different answers. Don't get them mixed up. The next thing you need to know about lumbar punctures is they're supposed to be sterile. So part of your job as the nurse is to help maintain a sterile field. So in the picture we're looking at, the doctor has sterile gloves on in the center picture. The nurse doesn't, and that's fine as long as you don't allow anything to contaminate the sterile field where the doctor is. And then another thing you can do is if you test the spinal fluid and it's got glucose, if you do a finger stick type glucometer test on it, one of the ways you can check right away if it's bacteria is it should be low in glucose if there's bacteria because the bacteria eats the glucose. If it's normal glucose, there's a good chance that they don't really have bacterial meningitis because it would be normal. I don't test on these vaccines, but I'm including it. Please don't memorize this slide. I'm only including it because every semester students ask me what I know about the vaccines. And so I've put all this information in here for you to look at if you're interested in the vaccines that are available. Like I said, it's not going to be on any test of mine. This here is to show the bacteria, how it can grow in the different wrinkles and sulci of the brain, and how the bacteria can form abscesses, and those abscesses cause permanent damage. So we definitely, this is the reason we want to get antibiotics on board as soon as possible. So the minute we have that lumbar puncture done, you need to start the antibiotics. If the antibiotics haven't come back from the pharmacy yet, you need to get on the phone and call them and find out why. And if they tell you it's going to be an hour, you need to call the director of the pharmacy because this cannot wait. Because if they have bacteria in there, you could be risking the patient's life by starting this antibiotics late. The next thing I need to bring up really quick is, and I don't test on this a lot, but be aware of encephalitis in kids. So in adults, encephalitis, a lot of times it goes hand in hand with alcoholism and things. In kids, it's more related to West Nile virus. And so mosquitoes can transmit bacteria, fungi, and parasites, and that can cause inflammation on the brain. And this is characterized or presents with fever and altered mental status. That's all you need to know about that. Don't study any deeper on that. The other thing is, as we talked about in the cardiac section, we talked about the two cases where kids are allowed to have aspirin therapy, and it was Kawasaki's disease and rheumatic fever. So in all other cases that I've taught you so far, they're not allowed to have aspirin. If they have aspirin, they're at high risk for Ray's syndrome. Aspirin doesn't actually cause Ray's syndrome. It just makes them at higher risk for getting Ray's syndrome. The Ray's syndrome is actually caused by being exposed to another individual that has influenza. And so you would need to teach the parents the signs and symptoms to look for if their child gets Ray's because they were exposed to someone with the influenza. Those signs and symptoms are nausea, vomiting, mental status changes, seizures, progressive unresponsiveness. That's all I'm going to ask you about that. Guillain-Barré syndrome is also called post-infectious polyneuritis. And this is also something I don't go that deep into, but you should know it's a post-infective disorder. It causes progressive musculoskeletal weakness and areflexia, denervation, and demyelization. This generally is reversible and self-limiting. And so if they do a lumbar puncture for a patient with this, there'll be high protein found in the lumbar puncture. The treatment is going to be immunoglobulins and mechanical ventilation in severe cases. This here is a picture of a child that has bacterial meningitis. And as you can see, the child's laying with their back arched, and that is because that's the most comfortable position. And you can see it's the opposite of chin to chest is. So this child will have a very hyperextended head and back to relieve the pressure on their spine. As a reminder, this is the Koenig and Brzezinski test, and the point of this is to the lifting of the leg is if you can't get the child to put their chin to their chest and you're not sure if it's nuchal rigidity, what you want to do is lift the leg enough to tilt the pelvis upward. And when you tilt the pelvis upward, that causes the spinal column to curve and that will elicit pain. So that is another positive sign that indicates meningitis. Headaches are an important topic. So you can have migraine headaches, inflammatory headaches, and tension headaches, vascular headaches. So there's the three here that are benign are the migraine, inflammatory, and tension headaches. So there's a range of triggers to do with this. Some people's headaches are triggered by foods. For example, I knew someone that was allergic to tomatoes, and that caused severe headaches for them. Nitrates, that would be triggered. So wine has nitrates in it, hot dogs, canned meats, things like that. Glutamate is a common trigger of headaches, and that is a component of MSG. So people with that generally avoid MSG. You can also have severe migraine headaches withdrawing from caffeine or being on caffeine, depending. Also, tyramine is a trigger, salt, menstruation, stress, fatigue, and hunger. It could be also just as simple as the patient needs glasses. So this is where asking the right questions of the patient can help narrow down what kind of headache we're dealing with. Also, some medications cause rebound headaches, such as decongestants. For example, if you take Sudafed and it reduces your nasal congestion, but when you stop taking it, the opposite happens, and this can trigger severe headaches. Also, think of things like opioids. So, if opioid's a pain reliever, then being off the opioid causes severe pain, and that includes headaches. So it's something we see a lot of times in withdrawal syndromes. The treatment for all headaches is going to depend on figuring out the underlying cause. So that's why if you can get it, you want to do a thorough history. Otherwise, when patients get discharged, we can have them keep a diary of every time they have a headache and everything that they did that day that was different. And eventually, over time, we should be able to figure out what caused their headache. Now, if you're interviewing a patient, you want to pay attention to the words that they use to describe their headache because that can tell us what's wrong. A vascular headache will be unilateral or bilateral, but the patient will almost always describe it as throbbing or pulsatile. They'll also have photophobia, sound sensitivity, nausea, vomiting, anorexia, and oftentimes they'll have an aura. Tension headaches. You can have a tension headache, out of the blue once or twice, but it's not medically diagnosed as a tension headache unless they have it more than 15 days a month. And these are associated with stress, lack of sleep, anxiety, low blood sugar. With this one, there's no vomiting, no anorexia, um, generally no visual changes. And then patients will describe this as a tight band sensation around their head. It's non-pulsatile, and they may or may not have any light or sound sensitivity. Inflammatory headaches almost always go hand in hand with um, allergies. So you can have sinus inflammation, nasal infection, and that'll happen with periorbital pain, possible fever. And this will be described as a dull, constant pressure. Um, and it can get worse when they move or change head positions. There's usually no visual or sound sensitivity associated with this. Those are the benign causes. So there's a couple of things that are more concerning that could be causes of migraines. So you can have a tumor, you can have a hemorrhage, or you can have intracranial pressure, which is secondary to meningitis or something else. So these are the hallmark signs of these are severe pain. Child wakes up in the middle of the night screaming. They have a lot worse pain when coughing or sneezing. They have persistent vomiting and visual changes. There's a couple of other structural defects we need to talk about now. So, babies, a lot of time, well, I don't want to say a lot of times, occasionally babies are born with a small brain, and the brain doesn't increase in circumference, it doesn't grow. And it's the pressure of the brain inside the skull pressing on the skull that makes the skull grow. So, this is why we track the growth of the skull for the first year or so of life, and we plot it on growth charts because that gives us an idea of if there's a problem with the skull growth, and that's called microcephaly. Hydrocephalus is an overproduction of fluid in the brain. Usually, it's in the ventricles, and they're going to often need a surgery. So you want to review the preoperative concerns related to this. So it's going to be positioning, providing skin care, meeting the child's nutritional needs, and providing emotional support. This is very painful for the child, and it's very disturbing for the parents. In the upper left-hand corner here, I have a picture of a baby that has microcephaly, and you can clearly see that the head isn't fully the grown to the right size. But sometimes it's more subtle than this, and so you would want to catch this immediately. The child on the upper right-hand corner, you can see that child's clearly in horrific pain with their arched back and the screaming the way they are. But also, if you look closely at the eyes, there's a characteristic look called sunsetting of the eyes. It's hard to see in this picture, but their eyes are rolled down instead of back in their head. And this is horrific pain the child is in. In the bottom left, you can see the treatment. So there's overproduction of fluid in the ventricles, causing pressure on the brain. So the treatment is going to be because it's going to be involving placing a shunt into that ventricle. Generally, they go down the center line of the skull so that they're in between the two hemispheres, and then they approach the ventricle from the side. As you can see, the tube comes out to the outside of the skull, and there's an access device there, and that's for where that access device uses a Luer lock system so that the nurse can clear if there can be crystals in there, there can be blockages. Sometimes they want to they can draw cultures from that. So it needs to be accessed sterilely, though. And so part of the nurse's job is to troubleshoot if there's a blockage in there or if there's an infection. If there's an infection, they can try giving antibiotics directly into the ventricle. But if it doesn't fix the problem right away, more than likely they're going to have to take the whole shunt out and replace it completely. And we'll talk more about that shunt in a minute, but I wanted to show the picture on the right side. If the child gets treatment, you can see that the head will go back to normal size. And if they do this fast enough, they can avoid permanent brain damage, although it would be unrealistic to think there'd be no deficits related to this. In this picture, you can see just how big the brain gets, and the child on the right has about half the amount of brain that the child on the left does. And so the bigger this gets, the more compressed the brain tissue is. That's less surface area for the brain to perform its normal functions. So this is something that needs to be acted on. In this picture, you can see the shunt and where it comes out. You can see the access device there. And then if you trace the line down the neck, you can see where the incision is, where this shunt, the tubing gets threaded under the skin again, all the way down under the skin into the peritoneum. And then the tubing gets coiled up. And the reason for that is the child's going to grow and they don't want to have to keep replacing this tubing. So they'll put enough coiling in there so that the child doesn't need the tubing replaced until they're generally in their adolescence. And at that point, they redecide. This is sterile in the peritoneum, so you can see that if a child had something like appendicitis that was ruptured and there was bacteria in the peritoneum, that would be a possible source of bacteria getting from the peritoneum up to the brain. So this is one of the jobs of the nurse to recognize these kind of potential causes of problems to the child that has a stent. So post-operatively, the child is going to need help with positioning. You'll want to help them be in a position of comfort. Their signs of intracranial pressure should be improving. And if they have a return of the previous signs, then that means something's wrong with the shunt. It would need to be reported immediately. So you're going to assess the vitals frequently. You're going to provide incision care because any infection would go straight into the brain. Monitor for signs of the shunt malfunctioning. Monitor for signs of increased intracranial pressure and infection. Neural defects are another thing in this chapter to take a look at. So in the beginning, in front load, we did an assessment, and you were asked to assess babies for a sacral dimple, and especially note if there was hair coming out of it or if you can't see the bottom of that sacral dimple. And this is why. Neural tube defects, generally these are associated with the maternal lack of folate during pregnancy. And sometimes that can be that their neural tube is exposed. In some cases, the neural tube can be completely evulsed out of that hole. So this would be presenting as lower extremity weakness, bowel and bladder dysfunction, ambulation difficulties, and hydrocephalus is possible. Babies can also be born with ancephaly, which means no brain. They can have an encephalocele, which is part of their brain is exposed. Spina bifida, that's when they have defects related to that spinal cord that are affecting their movement, and then meningioceles. This is a baby that has a myomeningeocele. So the key things to know about this is if the baby's born with this, as I've said before, it has to be kept warm, moist, and sterile. So the questions on the test would have to do with exposing the child to anything that would be a threat to that being warm, moist, and sterile. Also, positioning. So, a common question to ask about this patient with this is, as you know, most babies are supposed to be put on back to sleep, but this baby would be an exception because that would put pressure on this meningeocele. So, a good test question might test whether or not you know that this is an exception to that. Another thing students mess up on test questions related to this is students forget the difference between prone and supine. So make sure you know that for the test. So for myomeningeoceles, the disability that the child's going to have is going to be related to the level of the defect. So anything that's at or below the level of where the bladder and bowel function is occurring will affect that. Also, there can be complications related to this. So the child should always be placed in a prone position. You need to monitor that spinal sac for leakage of spinal fluid. There's a high risk of latex allergy because the spinal cord that's exposed is handled a lot of times by people that have latex in their gloves. That's less so of a problem since they started making hospitals latex free. So, but it's still a potential problem. The child, if they can't move their legs related to that, will have possible pressure sores. Nutrition can be an issue, and of course, elimination. Um, the only thing on this slide that you need to study is neonatal abstinence syndrome. So we had a discussion at the beginning of the class about that, and you should go back and refer to that for neonatal abstinence syndrome. There's one or two questions on it on the test, and you would need to know the signs and symptoms of neonatal abstinence syndrome and how do we measure it using the Finnegan scale, and you would need to review what's the treatment. So for opioid withdrawal, for example, the baby gets morphine around the clock based on their Finnegan score, and we wean them down slowly until they have no more withdrawal symptoms. So make sure you're able to recognize the signs and symptoms of the withdrawal that's particular to babies, such as sneezing, and you would also want to review the Finnegan score. Cerebral palsy is a non-progressive brain lesion or injury. These can occur in utero or during the birthing process, or they can even occur after birth. And this presents with muscle spasticity, flaccidity, abnormal posture, and abnormal movements. And it may or may not be associated with intellectual abilities. So, one of the interesting things about this particular illness is that people often assume that children or adults that have cerebral palsy are also going to have intellectual deficiencies, and that's not always true. Sometimes it's unrelated. So the disability depends on the location of the injury. There can be stiffness in muscles that are hypercontracted, and so the treatment for that is serial casting, braces, and positioning change devices. The patients are going to need help with elimination, mobility, they're monitored for skin integrity, safety, growth and development, and parental knowledge and support. Case manager is going to be needed to coordinate finances, mobility, therapies. And with all kids that have this kind of thing, a big concern is going to be transitioning to adulthood. So, starting maybe even as young as 14 or 15, the parents are going to be interested in um, most parents are going to be interested in if the child's going to be able to live on their own. Sometimes they can live in assisted living facilities or have semi-independent life styles. Sometimes they can have a job. Others of them are too profoundly affected to have that. And one concern is when the family ages, who's going to care for the child as they start to get old and near retirement. So those are all things that the nurse would be involved in. Brain injuries is a major problem with kids, especially related to trauma. And then loss of consciousness is a key part of assessing the severity of the injury. A leading cause, this is a leading cause of death and disability in children, especially when it's related to high velocity injuries like bicycle, ski injuries, sports injuries, assault, or motor vehicles. One thing you want to consider is that there's a primary injury to the brain and secondary injury. So primary would be related to the first problem. So um, for example, if there was the blunt force trauma, secondary injury, let's say after the trauma you had inflammation, you had infection, that's a secondary injury. So you're going to want to monitor for both of those. The type of injury and the severity is going to be considered mild, moderate, and severe. And one of the ways we measure the severity of the injury has to do with if the child, or this goes for adults too, if they lost consciousness, how long did they lose consciousness? Do they have any memory loss, and how long is that memory loss for? And also if they have excessive tiredness or fatigue and headaches. And then we also want to measure the Glasgow Coma Scale. So a mild injury, there's brief or no loss of consciousness and mild to no memory loss. In moderate, there's 5 to 10 minutes of loss of consciousness, and there's some amnesia and a Glasgow Coma Scale of 9 to 12. So this is why it's so important to do an interview in this case and monitor for those neurological changes. Um, for this one, this is called second impact syndrome, and because the brain floats in fluid in the skull, one thing you want to remind yourself of is that there's going to be brain damage in the front of the skull, or at least the direction that the brain was sloshing as the injury occurred. But then there's the whiplash effect. So there's bruising, swelling, and bleeding on both sides of the brain. So that's called second impact syndrome. In severe brain injuries, you're going to have a loss of consciousness of more than 10 minutes, a Glasgow Coma Scale of less than 8, and amnesia for more than 24 hours before the injury. You can have coma, and also you'll have signs of Cushing triad, which is increased systolic blood pressure, widening pulse pressure, bradycardia, and irregular respirations. They generally, with cases that are with smaller children, they're going to do a retinal scan to look and see if there's retinal hemorrhaging. Retinal hemorrhaging is associated with child abuse and not as much associated with things like motor vehicle accidents, so it'll help them differentiate if it's a non-accidental injury. Concussion is um, one of the less severe types of brain injuries that you can have. And with this one, it'll present with just headache, light sensitivity, brain fog, balance issues, nausea, vomiting, irritability, emotional lability, drowsiness, or maybe not being able to sleep, either one. And the recovery for this is 6 weeks. No sports. They're not allowed to have any screen time. All of that can trigger more seizures. And the more they have seizures, the more permanent the brain injury is going to be and the worse it's going to be. It's really important that they follow the restrictions carefully, whatever the doctor orders. For all head injuries, you'll need to make sure that you monitor and assess the neurological status every hour, especially in the early stages of the injury. Monitor level of consciousness, including Glasgow Coma Scale if necessary. Monitor vital signs, observe the breathing pattern, skin color, skin changes, observe the pain, gather as much information as you can about the circumstances around the injury and report any signs of decreased oxygenation or intracranial pressure. Because if there's hemorrhaging or bleeding in the brain or excessive swelling, it can lead to the brain herniation and death. For severe brain injury, it's important to maintain cerebral perfusion, and sometimes the only way they can do that is to relieve the pressure by cutting a flap in the skull, and then they would leave that open to air until the swelling goes down. Nursing interventions, though, you can start by putting the head of the bed flat to reduce pressure. You can prevent complications. You can dim the lights, protect the child from sounds and noises, remove visitors, remove the stimulation, because all of that's going to lead to more. It's possible that it could lead to seizures and more damage. Provide some emotional support to the family. Do as good of an assessment of any memory loss as you can. Monitor for seizures. Sometimes we put patients like this in therapeutic hypothermia. So if they're hypothermic, that can preserve brain um, because you lower the oxygen demands and the metabolic rate, and so that preserves brain function. And this would be a case where we would want them. We would also do that in the same case with drowning injuries. It also helps. And then medications, we would give mannitol and possible hypotonic solutions to reduce the brain swelling, and then monitor for long-term symptoms. With head injuries, if there's a scalp laceration, always monitor that for bleeding. One of the things I can't say this strongly enough. If you see bleeding from the scalp, you don't know if there's a brain fracture or not, or there could be brain exposed. You won't know if you don't clean it properly. So you have to be very thorough about cleaning that injury and making sure that there's no exposed brain or fracture. Sometimes with a skull fracture, the patient can actually leak cerebral spinal fluid from the nose or from the ears. So if you see clear or amber fluid coming from anywhere, if you don't know what that is, it could potentially be spinal fluid. You need to know that. One of the things you can do is test it with a glucose monitor to see if it's spinal fluid, because it will have some glucose on it. You can also do a Fern test, um, which is basically putting the spinal fluid on a piece of paper, and when it dries, it should look like a fern. Another thing that you should be aware of is spinal cord injury. So if you have a patient that has trauma, we can't rule out neck injury or spinal cord injury. So this is why we'll always put them in a C-spine collar and immobilize them until we rule out any spinal injury. Also be aware of the possibility of secondary infection from that. And then there's this thing called spinal shock. So you can get a concussion on your spinal cord, and that can be life-threatening. And so we want to monitor for any signs of that. Autonomic dysreflexia is life-threatening. It's a medical emergency, and the thing you need to know about this is it can be triggered by an overfilled bladder, constipation, or pressure sores. And what this causes is a massive overproduction of autonomic nervous system response. So the nursing intervention there is to prevent the patient from having anything that might trigger this condition, like make sure that they have their bladder emptied, don't allow it to become over full. Make sure that they have stool softeners so that they can relieve their constipation and always keep them from having pressure sores. This is just a quick picture that shows the mechanism of action for whiplash injuries in kids. And so the only thing you need to know about this is to be suspicious of this if there's possible shaken baby syndrome. And then finally, remember that drowning is common in children. If a child's been submerged in water longer than 10 minutes, then they have been hypoxic for that long. That means there's a delay in the CPR that's been given, and they're more likely to have significant brain injury or die if it was longer than 10 minutes. So we really want to know if it was witnessed or unwitnessed when they drowned, and we want to know how soon it was until they got CPR started. Sometimes if it's unwitnessed, uh, if they think that the child's been had drowned maybe 30 minutes or more previously, sometimes they won't even attempt to revive that child. There's an exception to that. So anybody that drowned in ice cold water or in the winter time is more likely to live. And so generally they'll have a much better outcome because I said earlier, hypothermic states help lower the metabolic need and oxygen demand in the brain, which preserves brain function. So a lot of times those kids will do a lot better. So even if a child has a near drowning incident and they wake up, we generally admit them to the hospital for observation for 6 to 8 hours because even if they survived the hypoxic injury, they could have secondary infection. So remember that the water that they drowned in isn't sterile, and so they could have pneumonia from that, or they could have a hyperreactive airway, and a lot of times they'll need to be intubated later because of that. Make sure that you give good parental education about preventing drowning, and especially let them know that kids can drown in things like buckets or toilets, so no standing water in the house. And if they're around anybody that has a pool or a hot tub, make sure that there's fencing around that. Parents should learn CPR. And then for teenagers, always warn of the risk of drowning and alcohol abuse. So, and then kids should always be watched when they're drowning. Make sure you teach parents to get the kids into swim lessons as soon as possible. That's about it. Thank you for listening.